Yes, this is a really interesting point. We have been seeing over the last few decades dramatic improvement and increase in the number of antithrombotic strategies that we have to treat thrombotic disease. But there's a huge gap between the difference between the use of antithrombotics in myocardial infarction and in stroke. So for myocardial infarction patients, they usually use a lot of different combinations of antithrombotic therapy, even anticoagulation within the setting of reperfusion therapies. In stroke, the antithrombotic medications are really contraindicated in the setting of reperfusion therapies, mainly with thrombolytic agents. But over the last few years, several new studies have shown that the use of selective antiplatelet agents may be helpful in selected populations of patients with stroke. Part of the problem is related to the fact that myocardial infarction has a much more homogeneous etiology for stroke. For MI, usually, 90% of the myocardial infarction are caused by atherothrombotic disease, and only 20% of the strokes are really attributed to a larger arteriovascular sclerosis. So there's a much more complicated scenario in terms of etiology. And it's probable that antithrombotic therapy may be more helpful in patients with atherothrombotic stroke, those related to intracranial or extracranial atherosclerotic stroke. So most of the new studies that have been shown the benefit of adding antithrombotic therapy on top of reperfusion therapy have been successful in the setting of larger atherosclerotic disease.